Thank you all for coming. Glad to see so many people come out at a busy time of year. My name is Mark Hansen. I'm the interim director at the Practical Ethics Center here on campus, and glad to have you here for the final presentation in our fall lineup, and certainly ask you to be on the lookout for our spring series. We'll be having a series of 5 talks again, generally first and third Mondays of each month, except when there is a holiday or spring break. So anyway, please be looking out for our spring lineup of speakers. I'd also like to thank Missoula Community Access Television for taping our series and putting it on local television. And when I ask those of you who ask questions or have comments during our presentation today to please speak up. So today we're very fortunate to have with us Ann Cook and to give a talk on ethics in healthcare. Just give you a few, know who she is, but just to give you some information and background about Ann. She's the director of the National Rural Bioethics Project and is associate professor of research in the Department of Psychology. Her research interests have focused on development and evaluation of health and social services in rural communities, specifically ethics-related issues that inform and complicate healthcare decisions. Conducted multi-method studies in the area in the West and has been supported by the Culpeper and Rockefeller Brothers Fund, the Greenwald Foundation, Agency for Healthcare Research and Quality, and the National Institute for Environmental Health Sciences, and the National Human Genome Institute. She's also developed and taught an ethics class for the Davidson Honors College. Her publications on rural ethics have created the foundation for a growing area of study, and she provides consultations and workshops on national and international level. Publication lists includes journals such as the American Journal of Nursing, American Journal of Bioethics, Journal of Clinical Ethics, and the Cambridge Quarterly of Healthcare Ethics. She has served as a member of the scientific review panels for the National Institutes of Health and is a member of the National Human Genome Variation Committee. So definitely a stellar background, and again, we're pleased to welcome you.
Well, good afternoon. It's very nice to be here. I was frankly surprised because I thought at this point in the semester with finals so rapidly encroaching that perhaps we'd have a very small audience. So either there's great interest in ethics or great interest in errors. But either way, that's what we're going to be talking about today. And this is an interesting field, and what I'm going to try to do is offer a context. Not really having any answers, because actually there really aren't any clear answers, but a context for thinking about the kinds of ethical issues that develop in rural communities, and for thinking about how healthcare providers and patients and community members solve those dilemmas. And I've tried to, with these slides, we'll have some images that perhaps will stay with you, so you can kind of call to mind some of these things as you try to make sense of two what seem to be theoretical issues, but issues that have real practical implication for our lives. The basic definition of bioethics. I mean, and this is a definition that was developed by Albert Johnson, who many would consider to be the father of the field. And he talks about it as involving the beliefs and obligations of the life sciences. And then he adds kind of the caveat that beliefs and obligations cover our moral values. And that's a good starting point. But it doesn't necessarily help us know exactly what we're talking about or exactly what that could mean. And so the moral archaeology, if you think about it, of the field, it's a very old field if you think about its roots. And obviously when people talk about bioethics, they often talk about the Hippocratic Oath. Or they talk about the foundational ethical theories, that developed by Kant and Mill. Or they talk about, landmark court decisions. Or they talk about, the progress that's been made with bioethics centers. Or evolving technologies. Or sometimes people talk about bioethics in relation to research scandals like Tuskegee in the syphilis studies. So that's kind of the background. But it more specifically started to really increase in more of our public understanding, probably in the 60s. Now, any one of those topics that I listed in the previous slide, any one of them could be the subject of a huge lecture all by itself. And this is just to give you an example. You know, one issue on this slide was the Nuremberg Code that developed after Hitler's World War II atrocities. And that particular body of legislation covered all kinds of issues like voluntary consent and the fact that when you're doing research, the scientific benefit has to outweigh the risk. And it said research has to avoid suffering, and research must never inflict intentional death. And so these were all part of a construct. But in this country, we never accepted the Nuremberg Code. And so we really didn't have any foundational codes that were underlying how we should approach bioethical issues until the late 70s, until we had the full impact of the Belmont Commission report. And again, that would be another long topic for conversation, but in general, you get a sense that this was a field that started evolving in the 40s, then to the 60s, and it's kind of really flowering right now. I thought it might help to give us some sample issues just so we could kind of align our frame of mind with the kinds of things we're talking about when you talk about bioethics, because it does have a way of sounding distant and academic. And actually, when we talk to rural healthcare providers, they often reference the fact that it's distant and academic. But so I've just kind of selected a few issues that kind of give us a frame for the scope of bioethics. And I started with 1946 just arbitrarily because it's kind of an interesting idea to ponder, and that was there was a whole issue called eugenics that was very, very popular in this country, and it began its popularity with Darwin's Origin of Species in 1859. So there was a tremendous interest in eugenics, and eugenics was considered to be a science. And it was a science that believed that reproduction and public health could be strengthened if you maximized those people who had the best genes, and if you minimized those people who had diseases who you thought could create a risk of public health. And so it was a way to resolve diseases such as epilepsy and mental illness and mental retardation, alcoholism. There was a very, very long list. And you'd think, well, how popular could something like this be? Well, between 1905 and 1910, eugenics was the second most popular article discussed in any of the popular magazines. It was a very popular topic. In 1920, Teddy Roosevelt talked about the prime duty of the good citizen to leave his or her blood of the right source for progeny. And then in 1942, the American Psychiatric Association talked about eugenics as a way of dealing with nature's mistakes. And I chose the date 1946 because that was when a gentleman named Herman Muller, who was a Nobel Prize winner, suggested that eugenics could be strengthened if artificial insemination was used to improve the gene pool. And so then one says, is that a justifiable way to ensure public health? Is that how we should do it in this country? 1957 was kind of an interesting year to ponder, because in 1957 we were making tremendous progress in technology. And so we were beginning to see that there's lots that can do with technology and how it interfaces with medicine. And I thought this was kind of an interesting year because in this year, the International Congress of Anesthesiologists actually appealed to Pope Pius XII to ask them to clarify the rights and obligations of physicians in either initiating or terminating life-saving measures. Because the International Congress of Anesthesiologists thought that sometimes life was being extended with technology. But that issue was also of importance because in that same year we were starting to see the real potential for organ transplantation. And so all of a sudden it was also kind of important to know with some clarity, when is a person really dead? And how long do you have to wait to be sure a person is really dead? Because in order to retrieve organs, you must retrieve them as soon as possible after the person has died in order for them to be viable. So all of a sudden, that became an important issue. 1962 was the famous Sherry Finkbein case. And that was a case of a woman who took a medication, hoping that it would relax her. She was in a very early stage of her pregnancy. And then she found out that the medication was thalidomide. And it was associated with very, very severe birth defects. And so she wanted to have an abortion. And so then we questioned, to what extent are we as a society allowed to make determinations of when life should be altered or changed or abandoned? In 1964 was an interesting issue because a group of women who had had illnesses, some of them for 17 and 18 years, begin to get a little bit of attention. And one woman in particular, one of the first women who began to receive more attention, had been sick for 17 years, ever since the birth of her first child. She had had hemorrhages, she had had cancer, her child had cancer. Well, they found out that she was one of 859 women who were receiving their prenatal treatment at the Vanderbilt Health Center. And at Vanderbilt, physicians and researchers initiated a health study because they were very curious to see the rate at which iron crossed the placental barrier. And so when the patients came in for their prenatal visit, they were given a little cocktail to drink and were told that it made them feel better. Of course, the repercussions for many of these women were very, very serious. In 1973, the National Institute of Mental Health floated a new regulation. And this was an interesting piece of work because it was a regulation that, since abortion was now legal, it outlined the guides for the use of newly delivered live fetuses from late-term abortions, with the understanding that the fetuses might be viable for a certain portion of time following the abortion, and how those fetuses could be used. What's interesting about this issue was when this issue became public, it generated a lot of attention. And Maria Shriver was in high school then, and she led her high school class on a march to Capitol Hill. And Ted Kennedy then kind of aligned himself with Walter Mondale, who had been working for years to try to create some kind of a commission to think about biomedical research. And then they kind of aligned themselves and began working towards what then became the Belmont Commission and the Belmont Report. 1986 was interesting because this is when we began to really have a potential for what we could do with gene studies. And in 1980, there was a family, the Wexler family, that had been plagued for generations with Huntington's disease. And it had affected the great-grandparents, the grandparents, the parents. And so the family put a great deal of their energies and their wealth behind the search for a cure for this disease. And they really believed that if you could find the gene and develop a test that indicated whether or not the person carried that gene, that then they could probably wipe out Huntington's in a single generation. That was their dream. And the person who describes and who has written about this study in great detail is the daughter of that family. And she found it amazing that once they discovered the gene, after all the years of work, she was not so very certain at all as to whether or not she'd ever want the test. And she was not at all certain as to whether or not she would not want to have a child. Because as she pointed out, in her family, Huntington's, though it's a devastating disease, its onset occurs at different times. And in her family, it was often a late onset. And so perhaps it would be worth a life, even if it's not a long life. And so for her family, the ethics of genetic decision-making was not so clear. In 1998, there was an interesting regulation called the Required Request for Organ Donation. And this is an interesting issue because you can really see how it evolved out of a sense of goodwill. What the required request said was that for all hospitals receiving Medicare or Medicaid funds, that if a patient is admitted and is either near death or has just died, that the patient's medical records must immediately be released to the organ procurement organization, so the organ procurement organization can review the records and can decide if they would like to ask the family to be organ donors. And that sounds like a reasonable request. After all, there are 50,000 people who are on the waiting list for organ transplantation, and a person who has died can't use his organs. But as a CEO of a rural hospital explained to us, the only problem is that organ transplantation and everything associated with it is very expensive. And so the only people who can receive organs are those who have some ability to pay for them or some reimbursement source. And so if a person does not have any insurance, a transplant center will not accept them for transplantation. Even the drugs to maintain the transplant are expensive. And as the CEO pointed out to us, the vast majority of patients who come to his hospital have no insurance. And he was wondering, is he under any ethical obligation to tell people when asking for organs that although this is good for you to do, this is not something that you could ever participate in? And you could see he was really struggling with this issue, because at one point he told us, you know, they've taken our gold, our silver, our timber. Now they want the last thing we have left. They want our bodies. So he was very much struggling. In 2000, there was a meningitis epidemic in Africa, and it coincided with a certain pharmaceutical company that was trying to develop a meningitis drug. And the interesting thing about the drug is that it would gain about $1 billion for the company if effective. And so the company decided to have their drug trial in this African town. And so they built a lovely facility adjacent to a very dilapidated facility that was run by the Doctors Without Borders. And in the Doctors Without Borders, patients were given an existing but effective treatment. And in the new facility, patients were going to be given the experimental treatment, but no other effective treatment. And so the question, is that an ethical drug study? Or say it's now, and you've been hospitalized and inadvertently given an overdose of insulin, actually given twice what you were supposed to receive. Unfortunately, although your heart stops, they're able to stabilize you, and you're going to be fine. And your healthcare providers explain to you that there was a complication with your diabetes, but you'll be fine, and there's nothing to worry about. Is that adequate information? Is that all you need to know? These are the kinds of issues that bioethicists struggle with in general. And what's interesting about those issues is that none of them, even the ones that go back to the 1940s, have ever been entirely resolved. I mean, pieces of them keep coming back and interfering with our lives and adding new dimensions and new complexities. Now, traditionally, like Albert Johnson, who's the father of bioethics, says that bioethics as a discipline can really help us respond to these kinds of problems, because he said scholars can elucidate the moral values that are behind these issues. He said that if you can have a disciplined way of thinking about these problems, if you can focus on the visible problematic instance, on the ventilator being turned on or turned off, on a surgery either being given or not being given, that you can kind of figure out the moral dimensions and figure out a way how to solve problems. And he advocated the use of the ethical theories, the deontological or utilitarian or virtue-driven ethics, and advocated use of the principles. The principles evolved largely from Belmont, but they were refined by philosophers and theologians like Beecham and Childress. And so the principles are these kinds of values, like beneficence, do good, and non-maleficence, do no harm, autonomy, respect the rights of people, and justice. And that was a framework that Albert Johnson and the traditional bioethicists have seen as workable in responding to the kind of problems we encounter. But in recent years, there have been other voices and other visions. And there's a growing cadre of ethicists and theorists who are saying, you know, the traditional approaches are not working. That has not been a good way, in a sense, to solve problems. And in a sense, it hasn't worked because it has decontextualized bioethics. By focusing on small, problematic instances, we've lost all of the cultural and contextual factors that give nuance and meaning to problems. And so a critic like Rosenberg is a historian, and he said that it's bioethics, the whole bioethical enterprise has become no more than hegemonic graphite, sprayed into the gears of machinery so as to still the sound of human pain. And someone like Carl Elliott says, you know, the money in bioethics is not hard to find. The traditional bioethics has resulted in centers and boards and classrooms and kind of an academic model. It's been largely embraced by pharmaceutical companies, but it hasn't really solved the kind of human problems that people face. And so what they're saying is that we have to have much more of a contextual-based ethics. We have to be thinking about, when we're making our healthcare decisions, who does what to whom, and under what circumstances, and to what effect. And when we start asking those kinds of questions, they suggest, we start to think about what might be most helpful. So what are the repercussions? The repercussions from these two disparate ways of kind of thinking about the discipline. Well, we have the institutional embodiment of ethics committee, institutional embodiment of ethics, which is the ethics committee. And if you read the bioethics literature, it suggests that ethics committees are largely prevalent in almost all hospitals. And we have a bioethics industry. But what's been very interesting is ever since the first bioethics committees were started in the 1960s, we have had very, very little assessment of the process or the product. We really don't know how well they work. We really don't know exactly what they do. Actually, we don't even know how prevalent they are. We don't know how satisfied people are with their decisions. And in some ways, some philosophers say there's no surprise in our lack of knowledge. Philosophers like DeVries or McGee say, you know, to an extent, and Margaret Nussbaum says this too, that the American analytic tradition of philosophy had a certain skepticism of empiricism. And so instead of kind of doing the kinds of practical, empirical studies that looked at decision making, they were more interested in kind of the conceptual overpinnings of the discipline rather than exactly what happens. So that's kind of the framework that kind of set us up for our kind of studies. We were very interested in trying to find out what ethical problems complicate healthcare in the world in which we live. And we were looking at originally first at a 6-state area of the West. And then that got expanded, so then we started looking at our 6-state area, and then we added New Mexico and West Virginia and Tennessee and Maine, New Hampshire, and Vermont. And then that changed again as we obtained more data. We are very much interested in looking at the contextual factors that shape healthcare decision making. And we're very interested in a collaborative agenda. So we're not just really studying healthcare providers, but we're working very closely with healthcare providers so that we can kind of work with and off each other. So as we get data, we share it with them. We ask them to give us comments. We ask them to explain. We go back and do more studies. So we've probably done over 15 studies now in the last 8 years. Surveys, focus groups, key informant interviews, textual analysis of case studies, many, many different methods to try to understand how ethical issues are approached. As we were dealing with ethical issues, another issue began emerging, a kind of ethics-related issue. Right kind of in the midpoint of our studies, the Institute of Medicine published a report called Error is Human. And it identified medical error as a very serious cause of death. As a matter of fact, if medical error if the National Center for Health Statistics identified error as one of the causes of death, it would rank number 5, ahead of AIDS and breast cancer and gunshot wounds and other problems. So the Institute of Medicine said error is a very serious problem. And it said that we need in healthcare a cultural change, a change from shame and blame to no shame, no blame, a system that emphasized individual responsibility to system responsibility, and a system that looked at non-disclosure to disclosure. So that was what the Institute of Medicine had to say. And then, of course, after this report, there was a tremendous amount of a generation of seminars and workshops and classes and grants, all to kind of look at the issue of error. And we received one of those grants and began looking at error as an associated issue in a 9-state area. So what did we find out? What did we find out first about ethics? It's very interesting, but basically when we would ask healthcare providers about ethical issues, they'd almost always start with a caveat. Well, I never encounter ethics issues, they would say, not ethical issues per se. Or they'd say, well, ethics, that's kind of a college classroom kind of a thing. That's not anything that we really discuss in great detail in our lives. And the vast majority of healthcare providers said they had never had any training in ethics, or if they had had training as a part of their medical school or nursing curriculum, it hadn't seemed to be very important. It had seemed to be kind of less important on the scheme of things that they had to learn. And what they would often tell us was, I don't have an ethical problem, but I have a personal problem. And so we'd say, well, tell us about a personal problem. And they'd say, well, a personal problem is like, I have to take care of a person who is a severe alcoholic, who has caused great devastation in the lives of others. And I'll be taking care of him and not taking care of a person who seems more worthy. And that's a personal problem for me. We'd say, okay. Or they'd say, I have an organizational problem. And we'd say, well, tell us what an organizational problem is. They'd say, well, an organizational problem is like, I know the person should receive a certain kind of treatment, but I also know that they do not have the resources to get that treatment. And so am I really helping the patient if I tell them about the treatment and tell them about what they can't have and what they could have if they had the resources? Or they'd often say, well, I don't have ethical problems, but I have professional problems. And we'd say, well, what's a professional problem? And they'd say, well, I think sometimes that harm gets done because according to the role and scope of my work, I can't, for instance, if a physician I know is using a very outmoded treatment for wound care, and the needed studies that should be done are not being done. But I'm not at liberty to tell the patient that, and I'm certainly not at liberty to question the physician because of the role and scope of my work. And so that's kind of how they would talk about ethical problems. They were very practical, down-to-earth things for them. What was also clear was that their ability to, what they've talked about as do good or do the right thing or make the most effective health care possible was compromised by areas of disagreement within the profession. And the areas of disagreement were both within and among professions, but especially among professions. There was very limited agreement about such issues. Who is our decision maker on the patient care team? Who is responsible for patient safety? What is an error? What is an ethical issue? How should ethical issues be resolved? There was very little agreement about those kinds of things. And so it made it very much more difficult to know how best to approach problems. There was a skepticism, almost uniformly, of formal models. The vast majority of hospitals where we did our research do not have ethics committees. As a matter of fact, most rural hospitals don't have ethics committees. And among those that do have ethics committees, the range of activities was very, very limited. Chiefly, they met irregularly, and usually they would deal with organizationally visible problem. And oftentimes, there were quite a few restrictions around who could refer cases or what the ethics committee would actually deal with. Context, overwhelmingly, healthcare providers shapes their willingness to action, to take action. So the context, and the context is influenced by relationships, by resources, and by perceptions of rules. The rules within the profession, the rules within the community, the rules within the hospital. And so your willingness to take action on any given issue is kind of a calculus of these factors and a sense that the repercussions of your behavior can be handled. And so we begun to see what that meant when we gave a survey to some nurses, to a large sample of nurses. We gave them 36 different ethics-related issues, and we asked them if they encountered the issue and if it was problematic and if they would take action. And actually, it was only a minority of issues that they were willing to take action on. For instance, one issue was orders for patients are unclear or confusing, and 75% of nurses said they would take action when they encountered that problem. But decreasing percentages of nurses were willing to take action on other issues because they didn't necessarily feel that they could handle the repercussions of their taking action. What was interesting was that everybody wanted resources. They all wanted resources, but they wanted resources, they said, that were different from the ones you usually see. They didn't want academic resources, and they wanted ones that were multidisciplinary. So what did we find out when we started looking at errors? Because we actually had a very good kind of template now on ethics for us to look at this related topic, and so we started to look at errors. And again, this was in a 9-state area, and we worked with interdisciplinary teams of healthcare providers in 30 research hospitals. One of the first things we did was gave them a survey that measured their cultural attitudes toward errors. And what we found out was that healthcare providers had a whole raft of beliefs about errors that were very consistent. They all believed that patient safety was very important, and they believed that their hospitals were very interested in promoting patient safety and were cognizant cognizant of the importance. They believed, most of them, that their hospitals had kind of no shame, no blame approaches to errors, that the hospitals encouraged the reporting of errors. And so basically, and they said they were comfortable talking about errors with one another when they filled out the cultural survey. But one of the things we did was use many different mechanisms. So then we also asked them to give us reports on what kinds of errors they'd actually ever reported. Because we're interested in their behaviors, not just what they think, but also what they do. And what we found out was that when they started talking about what they'd actually ever reported, those errors fell into two very narrow categories: medication-related errors, which would be wrong dose, wrong time, or wrong port, or patient falls. Those are the two things that they generally reported. We also found out that when we gave them when we asked about other errors, and then when we gave them case studies that depicted other errors, they weren't sure how to determine whether something was an error. So the disciplines had very different ideas about what constitutes an error and what you should do when encountering an error. And so at times they would look at a case study and they would say, this happens in our hospital, and this was not good, and the patient suffered harm, but it's not an error. So there were some real differences in terms of what they were willing to identify as an error. When we asked about diagnosis and treatment-related issues, there was almost a very uniform sense that those kinds of errors were almost never reported because they didn't really have a mechanism for understanding those kinds of errors or for knowing what to do about them. And so what happens is that there are two kinds of errors that were recognized: medication errors and falls. And those kinds of errors often involve nursing. And so most healthcare providers say that errors are associated primarily with nursing, and that nurses have the primary responsibility to make the system safe, because that's what they're recognizing. And when we then looked at what they're willing to report, what we found out was very consistent. They're willing to report the kinds of errors that they are sure are errors, and those are medication errors and patient falls. And it's very difficult to report other things. Learning relies on direct experiences, and cultural change is complex. And so when the Institute of Medicine calls for a cultural change, that's a very complex undertaking. What our research shows is that we need approaches that incorporate the context of care, including the working conditions. If we want to create a system that is as ethically sound as possible, and if we want to create a system that is as safe as possible, we have to somehow figure out how we incorporate the context of care. We need models that help healthcare providers and patients both cognitively and behaviorally recognize and experience issues. When we gave our healthcare providers the case studies, they found it was extremely helpful because they said inevitably these were cases that they had experienced. These were things they knew could happen in their hospitals. And so they said it was extremely helpful to work with those case studies because it could kind of almost set them up for being able to visualize how they could respond to them. And without that kind of practical resource, what was very interesting was the very limited amount of time that healthcare providers say they talk to one another, especially cross disciplines, that they just simply don't have the time to talk across disciplines. So we're trying to develop resources and models for our research hospitals that really support the recognition and resolution of ethics-related issues and patient safety-related issues. And we're trying to develop resources that kind of incorporate what's understood to be the stages of change. Because, you know, we like to think that change is a pretty quick and succinct, and if we just make up our mind to change behaviors that we can probably do it. But change is a very complex, multi-step endeavor. And some of the change theorists say that only about 10 to 15% of people who think they are in a change process are really in a change process at all, are really actively making changes. And so part of what we've been doing for the last 3 years with our ERRORS project is to really create resources that help healthcare providers recognize and anticipate issues so that they can then develop strategies to respond to them. There are no silver bullets, and education is a continuum. When we interviewed like medical students, young medical students, what was so powerful, you know, or even young physicians in their first few years of practice. I mean, I was thinking of a young physician who said, nothing in my academic training prepared me for the kinds of ethical issues I encounter in my practice. And so often they said that the kinds of ethical training they received in school seemed so distant and so unrelated to their lives, and what they needed was a much more practical agenda. But that practical agenda has to extend all throughout medicine and pharmacy and nursing school, and then it has to be woven in throughout the professional life. And it really has to be interdisciplinary, because if we have a system where the professions use such different words and different concepts so that they don't even recognize the same kinds of situations as ethically challenging or as safety challenging, it's going to be hard to develop any kind of responses that are really helpful. We found that in all of our studies underscore the necessity of focusing on the quality of the relationship. Again and again, what emerged from our studies was the sense that people take action when they think they can handle the consequences, when they have a relationship in place that's going to support them. And so we would have nurses who say, well, I'm not going to call and double check the order because I might get the phone slammed on my ear. Or I'm not going to do this because. Or a physician who would say, well, I don't want to disclose this because the patient may sue. So we have to really, really focus on the quality of the relationship, because the relationships seem like they are absolutely germane to what's happening in healthcare ethics. And we have to deal with real obstacles. I mean, so much of ethics has focused on kind of the big ethical issues that have been kind of the landmark issues of the field. But in rural healthcare settings, what people talk about is they have problems dealing with expectations of care and mutuality and dual relationships and burden of care and communication. And so we have to be willing to deal with very foundational issues that people have that get in the way of determining what is good care for people. And then in a sense, we have to change the questions. You know, so much of the impetus from like the Institute of Medicine's work with error has been to create a definition for error. So we could say, is this an error? Yes or no. Or is this an ethical problem? Yes or no. But maybe we had to kind of change the questions and ask more like, does it have to look like this? What would care look like if it was different? What are some alternatives? How could this be experienced differently by a patient? And so in a sense, move away from these black and white issues that really aren't helping us solve problems and move more toward these kinds of process issues that encourage and create dialogue. The indicators of an ethical environment are not so much one's adherence, we think, to a theoretical foundation like if you're a deontological approach or a utilitarian approach. We instead suggest that hospitals should focus on very practical questions, that these are going to give you a clue to whether people in your setting have a way to even conceptualize or deal with ethics or think about what might be most fair or most reasonable. So where and how do families get care? And how are people given bad news? And what are billing decisions? These are kind of the cornerstone issues that shape and influence our care. And they probably shape and influence then how we respond to ethical issues. You know, I think it's been clear over the last 7 or 8 years as we've been working on ethics and then more recently on patient safety that we all kind of want easy answers. And introspection is hard. But if we don't seriously think about these things, we're not going to recognize ethical issues when they occur. And we're not going to recognize patient safety issues when they occur. And so we're not going to really be agents for change in our facilities. We never, ever, in all the years we did research, we never had a healthcare provider who refused to take part in our studies when asked. They were phenomenally generous. We never worked with anyone who said they want to do things that are unethical or they want to make errors. What was so poignant was that almost whenever we would talk to healthcare providers about errors, they would remember things 15, 20 years ago that phenomenally shaped their orientation toward practice. And yet, the other reality is it is so easy, though, to get locked in our kind of perceptions, our cognitive way of doing things and think, well, I can't handle the repercussions of this decision, so I'll go this far and no farther. So we're really encouraging healthcare providers to, and patients really, to acknowledge that the actions they take will diminish or enhance the kind of healthcare that's available. And it's important to see these issues from another person's point of view. And I think that was part of the beauty of our research is that we've consistently been able to involve physicians and nurses and pharmacists and administrators. So we have in our studies this mix of perceptions that kind of give us a global picture of how healthcare providers are struggling to make the right kinds of decisions in an ethically complex environment. And given that, every situation calls for some restraint and some humility. Are there any questions? It's kind of a very fast-track pace through ethics of healthcare in rural settings, but Mark?
Just wondered if you could go back a couple of slides to, you were talking about indicators. About that one. Could you just say more about why you think, in what way those types of questions are actually indicators, and indicators of what?
This was an interesting issue, and these ideas were largely the work of a philosopher named Joan McIver Gibson, who was at the University of New Mexico. And she did a lot of work with the tribes, and what she was very interested in our research because she was seeing the same kinds of things, that there was an unwillingness to take action. There was an unwillingness to talk about ethics-related issues. When we asked healthcare providers, do you ever talk about ethics-related issues with your patients or with each other? They usually said no. Nurses often said, well, I don't really have the words to talk about ethics-related issues with patients. And they would say, and with each other, we just don't have the time to talk about ethics-related issues with each other. And so in this kind of arena where there is limited conversation, there are all kinds of decisions made about how information is relayed or not relayed. And that relayal of information really can determine the kind of care that's given, whether patients really are making autonomous decisions or whether they're not, whether they have the information they need. whether patients are really participating in decision-making or not, whether the whole healthcare team is functioning as a unit. And what we saw was that, interestingly enough, when we surveyed hospitals in which the nurses said that lines of communication were not clear in their hospital, they also said that errors were not reported and that they would not want their family members to be cared for in that hospital. And when healthcare providers, when nurses said the lines of communication were clear in their hospitals, they also tended to say that we're a member of the patient care decision-making team, errors are more likely to be reported, and we would be comfortable having our family members taken care of at that hospital. So in a sense, these kinds of issues, by asking these kinds of questions, it gets at these deep issues about, who makes decisions about healthcare and how that healthcare is given and under what conditions. And we'd say the same thing when we'd ask healthcare providers about ethics committees, and they'd say, well, only certain people in the hospital can make a referral to an ethics committee, or the ethics committee would never take this kind of an issue. So it's that same thing. It's a control of information. And these kinds of questions, they kind of form the backbone of what's going to be the treatment paradigm. And then from that backbone, then you are at a place where you can really talk about what is going to be good and what is going to prevent harm and what's going to support autonomy.
You made the comment in passing that doctors and nurses don't have enough time for various things. And I would say that that's an absolute cop-out, because people make time for what's important or what they have to do. And I think that this excuse indicates a lack of interest or fear of what's going to happen or criticism, those kinds of things. So whenever you hear that I don't have enough time, there's almost always something behind it.
I agree there's always something behind it. And so it's interesting for you as a physician to say that there's always something behind it. But there is the reality. And I think healthcare providers were very honest with us. I mean, they would say, like, a nurse in a rural hospital is probably on 5 or 6 committees. She might be the director of nursing, and she's on the safety committee and the patient education committee and the wound or infection control committee and something else. And so they'd very much say, I have time for something that seems really, really pressing. And I don't have time if it doesn't seem really pressing. And oftentimes when we first started asking about ethics, they would say things like, well, we don't have time for something like ethics in rural areas, because they perceived it as so distant and so disjointed from their lives. But I also think that, time involves this idea that I'm prepared to handle something, that I can talk it through, that I have the skills. I mean, that's all a part of feeling like I've got the time right now to deal with this. And the reality, I mean, when they were saying we don't feel like we have the words to talk about ethical issues, and we don't feel like there's a real support in our institution for discussions among the professions, that can kind of get lumped into this notion of time, that I don't have time. Physicians, one of the things they talked about was that they didn't have time to ensure informed consent. And that was interesting because they also talk about the fact that patients often fail to understand diagnosis and treatment. And so you could see that these kind of issues go together. But then that also gets back to these issues, are how are they given bad news, and how are they asked to make decisions? And so you have kind of a circle here. But part of that is wading through that idea of time and what you're willing, in the time you have, what you're willing to do, and the extent to which you think you can control the ramifications. And in general, if people thought they couldn't control the ramifications or the repercussions, then there really isn't time.
Unfortunately, we are out of time, but these are questions that face everybody all the time. And so thank you very much for very much.
Sure.